Good evening. Good evening. We are so excited to get started. Welcome. My name is Marie Boone-Clark, and I am founder and executive director of Birthing the Magic Collaborative. Thank you again for joining us in honor of Black Breastfeeding Week. I am one, thrilled to see so many of you here tonight, and two, excited to start this conversation. So many times we've had mamas say, I have no idea. And one practitioner said one thing and another said another. And so we're glad to have Dr. Kimberly walk us through a couple of housekeeping things. Drop your questions in the chat or in the Q&A. We'll get to those at the end if Dr. White doesn't cover them. We will record the session, so you have the ability to share it with your family and friends. And last but not least, it's my honor to introduce Dr. Kimberly White. Dr. White is a pharmacist. She's an innovator. She is a patient advocate, and she says decades of experience, but I don't believe it. She looks too young. But she has decades of experience ensuring medication safety and advancing maternal health. She brings clarity to some of the most confusing questions that patients face. Which medications, which supplements are safe for both mama, baby during the lactation period? So, Dr. White, thank you so much for joining us.
Of course. Thank you for having me. I'm trying to adjust my slides here. Hopefully everyone can see them. Can you see that?
We can.
Fantastic. Thank you, Marie, for the wonderful introduction and so warm. I'm excited to be here with everyone tonight. Gosh, it's midweek and you can you can actually be anywhere. And you've chosen to spend an hour with us. So I'm very excited about that. Can you hear me okay, Marie?
Yeah, yes, we can.
Fantastic. So as Marie mentioned, I have the distinct pleasure to meet with you guys tonight and really talk about why maternal medicine does matter. I mean, when we talk about medications, there's so many of them. There's almost 7,000 prescription medications. And then if you put on top of that another 200 to 300,000 over-the-counter medications, my goodness, there's bound to be questions and misinformation and myths and so many other things. So hopefully I can bring some clarity tonight, but as you guys know, in the pregnancy space, we have a couple things that we have to wrestle with as well to get to some of the really good information that we do have out there. So as mentioned, I am the founder and CEO of PharmaCare Solutions. And this is a pharmacist-led flies. And it has really been a blessing because I did have the opportunity to do one-on-one with my uh-oh. Can you guys hear me okay? I'm getting a weird internet message. Okay. I have the opportunity to do consultations and sit down and go through medication reviews and have an opportunity to go through duplications, interactions. So I have patients that really have started with multiple medications and we had a chance to whittle it down. So medication education is super important to me. So this is right. I'm in the right place at the right time. So as we get started, I do want to kind of level set. We're going to talk a little bit about pregnancy and breastfeeding. And we're also going to talk about medications and supplements when doing so, because it is very important that we have some good information. Sorry about that. And this is like in the middle of my screen here. So sorry. Hold on. Let's see if I can move that. So let's go ahead and get started. So the workshop tonight, we're going to walk through a couple different areas. So we're going to talk about pregnancy and lactation and how how medications and supplements are processed in the body. And then we're going to talk about medications and supplements that are typically safe, some are risky, and some are understudied, particularly during breastfeeding. And then we're going to also talk through some tools and resources like Black Med and infant risk so that you can have an enduring tool and resource to use to kind of go through and level set and navigate lactation. Because after tonight, I'm sure you'll have more and more questions, and you'll have an opportunity to use those resources to help you. And then we're going to just talk a little bit at the end about cultural practices, health inequities, and how decision making for Black moms and birthing people is ultra important. So let's hop right in. So the whole reason we're here tonight is to talk safety and to better understand why safe prescribing in maternal care really does matter. So if you look on the right side of the screen, you see the medication use in pregnancy, and it is about 90% of people use at least one medication, and of that 90% of those, it's about 70% use prescriptions, which is a lot. And the reason I say that is because less than 10% of drugs actually have adequate pregnancy safety data. Because typically, pregnancy patients or people, excuse me, are excluded from clinical trials. And that's where practice guidelines are extremely vital. So 84% of pregnancy related deaths are preventable. And I would say, just along with you guys, that safe prescribing is part of prevention. So as we get started, it's really important to level set to understand that Black women are 3 times more likely to die than white women when it comes to maternal care, and that is unacceptable. So another reason we're going to talk about medication safety is that there's potentially harm that can occur. And excuse me. Okay. Sorry. My goodness. There is this big bar that's like in the front of my face. Okay. I think we're okay now. Let's kind of move on. Uh-oh. Now I'm stuck. Uh-oh. Okay.
Bar
There
your,
we
oh, I was just going to ask Dr. Kimberly, is the bar your name tag that's part of our Zoom thing or no?
Oh, it's part of Zoom, but it's okay. I moved it. I was
I
able
wish I
to.
could remove it. Okay.
Thank you. So, what I was saying about medications safety is that potential harm is really important because there's so many myths out there. One is that natural supplements are safe. If it's natural, it's safe. And natural supplements can be harmful, especially to a fetus or a nursing infant. They can sometimes cause birth defects or cause complications of pregnancy or infant side effects as well. So, undertreating different conditions can also cause harm as well to both. And that could be tricky because, again, there's not a lot of really good randomized placebo controlled trials that have been done in in infants and certainly in pregnant people as well. So the other thing that is keep giving us a run for our money is changing guidelines. So, healthcare guidelines around pregnancy and lactation really do evolve as research comes forth. So, when new things come about, you'll see changes by ACOG, perhaps you might even see something by CDC. But the other thing that I wanted to mention, and I'm going to get into here shortly, is an example is the old FDA pregnancy risk letter categories. And this was retired in favor of more safety information. But this is kind of old school. So when I'm going through this information with you so that you'll have a backdrop into when people say, oh, it's pregnancy category B or X or what have you, you'll have a better understanding of what that means because it's all about safety. So before I get into that, so many pregnancies are unplanned. But for those that are planning a pregnancy, they they all have one thing in common. They have to start getting their bodies ready. So when you talk about that, ingesting certain um, vitamins like folic acid, iron, vitamin D, calcium, iodine. And so when you couple all those things together, it is definitely getting the body ready for reducing risk of neural tube defects in low risk patients. There's the dosing mentioned, but high risk patients certainly have to get their bodies ready as well. And then iron supplements are in place if there's anemic patients or women, excuse me. And then calcium and vitamin D really work well together. And they are recommended and they're safe and they're again getting the body ready. So a standard prenatal vitamin is usually pretty safe and encouraged. And for those that are trying to find the right one, typically you have to take it with food, and because there's vitamins and minerals included in the formulation. So sometimes that can make patients rather nauseated or even vomit. And so sometimes, again, getting the body ready for things like that, you would take that with food. And of course, avoiding anything like alcohol or smoking or other substances prior to pregnancy is really important, again, to get the body detoxed and ready for this whole process. So what you see in front of you is this really busy schematic, I will say, but it's physiological changes that take place in pregnancy, and there's a lot going on. The body goes into overdrive, and so I'm going to start on the top left. But the body just does a number of things, so it affects these four really critical areas when it comes to pharmacokinetics, and that's just a big word for how the drug actually works in the body. So in pregnancy, if a woman is nauseated, that is going to be a deal breaker with respect to adherence. But if they, for whatever reason, vomit different medications, then that reduces the drug intake that's available for the body. So when the body is getting ready to excuse me, supplement the embryo, of course, or the fetus, then you definitely want to make sure that these are timed properly so that there's neither nausea or vomiting, and that the patient is pretty okay with their regimen. And then there's other things going on with reduced gastric emptying. So sometimes the drug just kind of sits around, and there's reducing the maximal drug concentration available. And then sometimes what happens in the stomach is the gastric pH goes up. We all know the stomach is rather acid. So if it becomes a little bit more basic, then that affects absorption of different molecules or drugs. So let's move on to distribution. So if you think about how the body works, there's an increase of total body water, and there's this whole expansion of plasma volume. So think about going from a bathtub, to a swimming pool. Now you have a larger volume of distribution for medications that are relatively affinity. They do well and dissolve and metabolize in water. But then the body also increases body fat, and the volume of distribution for lipid drugs, lipophilic friendly drugs, have a larger pool, and that does affect the drugs as well. Now, there's a protein in our body called albumin, and that is going to be important because in the body, in the mom's body, albumin is actually reduced by different hormones in our bodies. And then that makes more free drug available for effect or metabolism or elimination. So on the right side of the screen, we see that there's all sorts of enzymes that are either induced or inhibited because of progesterone and estrogen. And so that can affect metabolism of drugs. And then that can either inhibit drug um, metabolism or induce it, rev it up a little bit more. And then there's elimination. So there's increased renal blood flow. So blood flow in the kidney. And then there's an increased filtration rate, which means that the drugs themselves can be eliminated far faster than they need to be. So sometimes there's dose adjustments that need to occur. So all of these things are happening at the same time and in different ways, but this is the backdrop of what's happening in pregnancy. So when you think about selecting a drug, here's a couple tips. So one thing that is important is to select drugs that have been around for a long time, that's used safely, and if possible, starting on the lower end of that prescribed range. And that way, you and your clinician have shared decision making when it comes to increasing that dosing range. And then if pregnant people could, they can eliminate non-essential medications and avoid self-medicating. In other words, if one capsule's good, two's better. We're definitely not going to do that because again, safety is everything. So speaking to clinicians about just how to get the dose right and also preventing any harm to mom and baby is of ultimate importance. So speaking of safety, there is something called a teratogen that we're going to get into, and that's an infectious agent, a drug, a chemical that causes different alterations to the fetus. And that can look very differently. It can affect fetal function, morphology, and exposed during pregnancy. So sometimes there's a teratogenic mechanism that can't be explained. And then sometimes it could be a direct effect of the drug on the fetus or and a consequence of a physiological change in the mom or the fetus. So there's some examples listed below, and they could be pretty serious, like cleft lip palate, excuse me, cleft foot, neural tube defects, and then sometimes with there were a few medications that cause missing and malformed limbs and fingers, and that is a no-go. We definitely don't want to do anything like that. And then there can be behavioral or biochemical abnormalities as well, and you'll hear more about those types of medicines here shortly. So next, let's talk about timing. Timing is really important when you're talking about drug exposure and what impact that has on fetal development. So when we talk about why this is important, we go back to safety. The incidence of congenital malformation, which is a big word for birth defect, is about 3 to 5%. And about 2 to 3% of all birth defects are caused by some medication exposure. So that tells us we have to be ultra careful when picking the right product for the right disease state or illness and starting it really at the right time. So let's move on to what the timing and how that really is important. So before the 20th day after fertilization, drugs given at this time typically have an all or nothing effect. Either the embryo is killed or there's no effect. But teratogenesis, as I mentioned before, is unlikely during this stage. But if you're talking about organogenesis, which occurs about 20 to 56 days after fertilization, well, this is where it's most likely. This can cause miscarriage, spontaneous abortion, really gross anatomical defects. There could be an increase of cancer, childhood cancer risk, or there could be no measurable effects. But in the second and third trimester, teratogenesis is highly unlikely, but drugs can affect growth and function of normally formed fetal organs. So again, timing really does matter. So this is just a better schematic to help you see exactly what I just said. So in the first 3 weeks, the risk increases, but it really goes up rapidly after week 3. And it peaks somewhere in the middle between 3 and 6. And then the risk is lower after 8 weeks. So I know this picture is a little bit blurry, but I put this in here because I mentioned this before. This is the FDA pregnancy categories for drugs. And I put this in here simply because I want you to understand that, like most of the medications that are on the market, fall within this B and C range. So I think we should walk through what each of the categories actually mean and how it's applicable to picking a medication. So the first category is category A, and this is the sweet spot. This is, we don't want any fetal risk in control studies. This is like your vitamins, levothyroxine, like levothyroxine is mentioned here. And then B is where there's no risk to human fetus, despite possible animal risk or no risk in animal studies, but there are lacking human studies. Sounds okay. But then C is human risk can't be ruled out. Animal studies may or may not show the risk, but there is a risk somewhat mentioned here. And then D is is evidence of risk to human fetus. And then X is contraindicated in pregnancy. So we're going to talk about each of these areas. And of course, that, like I said, the sweet spot is A, and we definitely want to stay away from X. And so we'll do those drugs towards the end of the presentation. But just be aware, and as we're going through the presentation, kind of look for some areas and medications so you can make the connection. Okay. So here, the next couple slides, we're going to go through pregnancy-induced illnesses. And we're going to start with pain and nausea and vomiting and also GI medications. And so we'll talk about some of the pregnancy categories. And it's strange because some of these categories fluctuate based on trimester. But for the most part, I put like acetaminophen here as the drug of choice, the go-to for analgesics and antipyrate for fever, antipyretics. And it's typically pretty safe, but there's a maximum dose every single day of 4,000 micrograms or 4 grams per day. And when you're talking about nausea and vomiting, this is super important. These medications mentioned with pregnancy category B, meclizine or cyclizine, have, for the most part, the first two have been considered safe, and there's not a lot of information showing otherwise. And then metoclopramide is listed here, and it's usually during labor and anesthesia, but ondansetron is here as well, and that's pretty commonly prescribed. And then dexamethasone and prednisolone. This is for your severe cases of vomiting, and this has been associated with high risk of oral clefts as well. So when it comes to diarrhea, loperamide is a category B, but again, use it with caution, because if you are using it to treat diarrhea, then there's volume changes that you want to watch for, and you don't want to become dehydrated, and thereby that affects the drugs and what can happen with the baby as well. So I put common cold here, but because some of these medications are included in cold remedies, so I really should have put antihistamines. But some of the, you could see these are listed, and you'll probably note diphenhydramine as a category B, but it's a sedating antihistamine, and the others are more non-sedating antihistamines as well. But when it comes to cough, these are the types of medicines that use with caution, and like guaifenesin is an expectorant. It's a category C, only as needed. I mean, there's kind of conflicting information out there about that, but there's also kind of, you have to weigh risk and benefit and figure out if these are the medications that can help, at a really bad cough, or if you're trying to keep your immune system strong. So this might be an option if talking to your clinician, you guys agree that this is an option for you and in that C category. And then when you're talking about heartburn and dyspepsia, I have it listed. Most of these are pretty safe, with the exception of, like, most of the antacids are listed at the top. And then there's other medications that are safe as well if there's more persistent symptoms. And the safest in this category is lisinopril. Okay. I'm calling it the heart medicines. But this one is listed as the safest PPI in pregnancy. And then moving to the bottom is the laxatives. So sometimes there's reduction in GI motility, and there's some constipation that happens. And we talked a little bit about absorption before. So some of these bulk laxatives are in place just to, it's pretty safe for simple constipation. So going for the brand, the psylliums, the methylcellulose, the ones that aren't addictive, like your Sennas or your Cascara sangradas. Docusate sodium is also included here because it's a stool softener as well. So that might make the go a little easier. All right. I'm looking at the time here, and we're at the half way mark. So I'm gonna go a little bit faster because I'm not even halfway through my slides yet. So let's move quickly. So when we talk about the next group of disease states we're going to talk about are pretty common. So when I told you in the beginning, there's so many drugs and so many disease states that we could talk about, I had to kind of pick and choose which ones to focus on. But we can kind of go through this pretty quickly. And if there's any specific questions, that do let me know towards the end. But hypertension in pregnancy is a big one. And we know that the go-tos medication, first line therapy, is methadone, labetalol, and nifedipine extended release. So when you talk about the different types of hypertension, chronic hypertension is the blood pressure that was there prior to pregnancy, and that kind of speaks to 1 to 5% of pregnancies. And then gestational hypertension is the high blood pressure that occurs after pregnancy, about around week 20 or 26 or so. But usually these are typically resolved. This hypertension usually resolves within 4 weeks after delivery. And this accounts for about 5 to 10% of pregnancies. This complicates about 5 to 10% of pregnancies. So we talked about the first line medications, and some are contraindicated. And ACE inhibitors are on that list. They have an increased risk of fetal urinary tract abnormalities, and ARBs are as well because they have an increased risk of fetal renal dysfunction. And there's some things that happen with the lungs and the skeletal malformations and even death. So we definitely want to stay away from this class of drugs. And then treating, I'm not going to read everything, but treating severe hypertension, 160 over 110, is so important for prevention of stroke. And then preventing eclampsia is a medical emergency, and that's certainly important. So I mentioned some of this already, so I'm kind of going to go through this one quickly, but I wanted to kind of point out for women at high, the second or the colorful part of the slide, for women at high risk for preeclampsia, low dose aspirin after 12 weeks. We're going to get into that in the next slide, but it's really important that these patients receive this low dose aspirin because it reduces the risk of preeclampsia by 19%. There's low dose aspirin that does reduce the risk of preterm births also by 7%. So, and fetal and neonatal death by 16%. So this is something that is important to remember, and we want to make sure that as we're going about and making sure we identify who's appropriate, this is going to be very, very helpful, especially in those with high risk or moderate risk as well. So calcium is recommended for these patients, and again, staying away from certain medications, and then other drugs to avoid magnesium sulfate, except for eclampsia prevention and to treat eclampsia related seizures. And some of these other medicines are deal breakers as well, so we're staying away from those. So speaking of the low dose aspirin, I'm going to kind of go through this. Needless to say, several associations and the Preeclampsia Foundation recommends this low dose aspirin after week 12 until 28 weeks of gestation. And this is really important again for those high risk individuals in the middle of the page. And I'll let you read through that. But also, so people with a history of preeclampsia, if there's someone who has had chronic hypertension or diabetes, kidney disease, and there's a couple autoimmune diseases as well, but there's also a room for pregnant individuals with more than one or several moderate risk factors, and being Black is one, and overweight or obesity, excuse me, and a family history of preeclampsia. So that you can read through this very wordy slide. My apologies. I was trying to keep it short, but there's so much information that I wanted to share, but just understanding that safety data really is favorable for aspirin in this patient population, and there hasn't been any postpartum hemorrhaging complications seen, and major GI bleeds, no placental abruption, and no birth defects or ductal closures. And this is quite opposite of high dose aspirin, and that's everything over 300 milligrams. And again, low dose aspirin is around 80 milligrams. Mentioned here, it's usually 81, baby aspirin is, but in some of the literature it said 80. But yeah, so keep that in mind. And this is definitely an area as clinicians, we can identify who would be appropriate candidates. So next we'll talk about diabetes in pregnancy. So what I didn't say about hypertension is some of these disease states, of course, clinicians start off with non-pharmacologic remedies or approaches to managing patients. And diabetes is no different because there's 1 in 20 women that do have gestational diabetes. And this occurs during pregnancy and it's associated with a number of complications. So when non-pharmacologic measures aren't making a splash, like measuring blood sugars and diet reinforcement and walking, then insulin is usually first line. It cannot cross the placenta, and it gives a very predictable glucose control threshold. And it doesn't really matter if it's type 1 or type 2. And for some women with gestational diabetes, this really does help them a lot. If not, metformin is another option. But keeping in mind that the goal here is tight glucose control, and gestational diabetes is something that there are treatments out there. So we just have to be mindful and watchful for those individuals that fit the bill. So asthma is next, and I'm going to go quickly through this. But the effect on pregnancy actually varies, and a lot of times with asthma, most kind of know how to manage their episodes, and deterioration is slightly more common than improvement. But most pregnant women don't have as many severe attacks. But again, the medications that have been used, they chances are they're probably on them, but inhaled bronchodilators like albuterol is first line for rescue. And then inhaled corticosteroids like budesonide is preferred as first line. And then if there's some other interventions that need to be um, in place, it's usually methylprednisolone 60 milligrams IV, and then it's followed by an oral regimen just to taper the woman off. But yeah, these corticosteroids really are important in this group. And next, we're going to talk about depression in pregnancy. So this is a pretty hot topic right now, and ensuring that patient or pregnancy is doesn't stand in the way of treatment is ultra important for anyone that needs to be treated. So pregnancy is has been in the media a bit lately simply because there's controversy and there's two sides of treatments or considering treatments is to treat or to not treat. And then when you talk about treatment, what does that mean outside of therapy or psychotherapy or behavioral modification therapy or what have you? And there's a ton of different things, and I'm just kind of making that general catch-all. But when you talk about treatment, there's so many different schools of thought about SSRIs. They're commonly used, and there are a couple medications that are preferred, but the thought is should clinicians or pregnant women actually go through specific education before they start them, or if they get pregnant and they're on them already, do they wash them off, or is there a washout period, or do they stay on, and when do they restart? Like, it's so many different directions in terms of this conversation. There was a recent FDA expert panel that kind of was convened, and it left some people more confused and some people really not having a straight answer as to what to do. But one thing that was clear was education, and it was really calling on the pharmaceutical companies to level set their package inserts or product monographs so that they're a lot more clear and that patients know exactly what has been seen in clinical studies and animal models, and how they are proceeding to make the connections that they are making or draw the conclusions that they're including. So in these discussions, I think it's very important for the clinicians to have shared decision, or the pregnant woman to have shared decision making with the clinicians in whatever they decide. When you're talking about breastfeeding, some of these, SSRIs and other antidepressants are compatible with breastfeeding, but treating different the maternal mood is really a higher priority, is a high priority. So weighing that with the risk of side effects or long-term effects for mom and baby is definitely up for discussion. So when you talk about SSRIs, and I think I have another slide, lately there needs to be really the risk. The benefit has to outweigh the risk. and talking about the full picture of treatment, and then monitoring the both mom and baby along the way. So when I put venous thromboembolism on here because this does happen, and low molecular weight heparin or unfractionated heparin should be used in this in the duration of pregnancy and for 6 weeks after delivery. Warfarin should definitely be avoided after the first week of gestation, but this is really for patients with risk factors that include increasing age, history of thromboembolism, and a number of other things that you can read on the slide. My goodness, I'm not going to get through all these slides. Let's go quickly through urinary tract infection. I put this in here because this does happen. This definitely does happen. There's antibiotics that are safe and effective. And then you can see that cephalexin is on the top of the list. And then there's a couple that have certain time frames that they're more efficacious. And then fluoroquinolones and tetracyclines should not be used at all. I'm going to skip through some of this and get to, I do want to talk about alcohol. Alcohol is one of the most commonly seen teratogens out there, and it increases spontaneous abortion that is likely to be associated with alcohol consume, but there's really no amount that's known to be risk-free. So when drinking, regular drinking has been shown to decrease birth weight by 1 to 1.3 kilograms. And binge drinking really can cause fetal alcohol syndrome, as well as growth restrictions. So it's the leading cause for intellectual disability and neonatal death due to failure to thrive. So I put this in here because it's most accessible, and this is something that we should be aware of. Cigarette smoking is also, this is one of the top addictions in pregnancy, and it has a known list of increasing risk over time. And we want to make sure that if the moms are ready for smoking cessation programs, that is available to them. I wanted to mention cannabis. So THC is the main metabolite of cannabis, and it does cross the placenta, and recreational use of marijuana does appear to increase congenital malformations and restrict growth. So thinking about, talking to people about marijuana use is important. And then there's some street drugs that I mentioned on here. And again, there are repeat offenders in terms of spontaneous abortion, preterm delivery, and withdrawing. So next, we'll talk quickly about opioids, and then I'm going to kind of move on to supplements, I think, if that's okay. Marie, what do you think?
Yes, I was going to say, doctor, we you guys tell me in the chat if I'm wrong. We don't have a hard stop.
Okay.
I'm fine. I think we're finding a lot of richness from this conversation. So,
Oh, okay.
and this one was on my list because
Oh, good.
anecdotally there's a lot of confusion, and we get mamas who talk about what they're told that they can and cannot take. So, um, and we can always have you back for phase 2 if we want to move the supplements to phase 2. We can do
Okay.
that as well.
Yeah, yeah, of course. Because I have, let's see, it says I'm in slide 28 and I have quite a few more to go.
And everyone
But
is saying, yes, please continue. This is such important information. Please don't shorten your time. This is great.
okay, good. Very good. Okay, very good, very good. So when we're talking about opioids is another one that's in the news right now. And it's important because there's an ACOG committee opinion, as I didn't mention that, but several of these have been written up with respect to ACOG's opinion. And I say ACOG obviously because it is relevant to the topic. But when you're talking about opioids, thinking about the different classes of opioids, and it's basically set on their controlled substances, of course, but it's based on abuse potential and tolerance. So opioids themselves, they readily cross the placenta, and it could result in opioid dependence in the fetus, because this is what happens in the mom's body. So something like heroin is a controlled substance category 1, and then morphine is 2. And so it has to do with how addictive this allows, how the addictive this is to our bodies. So neonatals may have withdrawal symptoms anywhere from 6 hours to 8 days after they're born. And use of opioids really results in congenital malformations. And so to kind of talk about that further, it is a dilemma, right? Because some of these patients need pain meds and treatment. And when you go through the recommendations from ACOG, there's a whole list of things that they want you to do. But in terms of making a decision, you're really making it with both mom and baby. So during the pregnancy, the risk of pregnancy complications do increase. Again, spontaneous abortion, abnormal fetal presentation, as well as preterm delivery. But they have other medications called opioid partial agonist therapy, and that just has everything to do with how the drug itself binds to the opioid receptors in the brain and in the body, and it could be associated with a lower risk of neonatal withdrawal versus what methadone can do. And it can be increasingly used for patients that are opioid dependent during pregnancy. So this medication is really picking up steam in those that are trying to withdraw from opioids. And this brings me to a point that I think I mentioned it later in the slides, but I'll go ahead and talk about it now. But there is a drug called 7-hydroxymethyltryptamine, and it is a active ingredient that comes from a botanical called kratom. And this is the newest kid on the block. So it's a technically synthetic opioid that again binds the opioid receptors in the brain. And guess where it's available? Gas stations, online, smoke and vape shops, and convenience stores. So this now has been in the news, and even the FDA is now pushing to ban it across the United States. Some states have already banned it, like I think last week it was Florida that banned it. But this is a important topic because people who are in pain are now going to the gas stations and they're picking up these nicely brightly colored packages that include gummy bears, ice cream cones, um, liquid shots, energy drinks, candy bars, like you name it. They've got it. And it is very addictive. It's 13 times more addictive than morphine. And it is the new craze. So there's no withdrawal protocol right now. So people, and perhaps I was listening to the Florida news, and they were talking about how the ER visits are up, overdoses are up, and now again, there are a few deaths, but they're having trouble associating them. But just again, they're going for controlled substance category 1, which again is the most addictive. So be on the watch for that. because that is definitely, and I was reading about how a lot of pregnant patients now have gotten a hold to it. And you might ask, how is this possible? Well, dietary supplements, it's labeled as a dietary supplement. So kratom is a botanical that has they call it 7-OH or 7-O. And it is a just in kratom in trace amounts. And so now companies have taken that, extracted it, concentrated it, and they're selling it as a dietary supplement. So it's actually pretty sad because kratom is used for depression and anxiety, as well as to get off of opioids. And now these people are more addicted. So I wanted to bring this up because this might be the buzz that you're hearing in our pregnancy community. I put caffeine in here simply because it's a drug. It has different phenols in it as well, but caffeine itself is an offender, right? So in small amounts, it seems like there's no little or no risk to the fetus, but in large amounts, 7 cups of coffee a day is apparently pretty risky. So some data really actually shows stillbirths and preterm deliveries, low birth weight, and even spontaneous abortions. And they seem to think that decaffeinated beverages are no little or no risk to the fetus. And of course, sweeteners are going well. Um, as aspartame during pregnancy is often questioned. So I always kind of would say for those that drink, they seem to think less than a liter of diet soda a day is okay. But this is one of those where they do have a metabolite that's concentrated in the fetus. So not really sure about what it's doing to intellectual disability. So again, put that on your radar and let's kind of watch that. All right, so let's talk about medication safe in breastfeeding. So breastfeeding is super crucial. I think everyone knows that here from a long-term and short-term basis, but it also is so good for reducing infections and lower risk of obesity in childhood and even adulthood. But it also helps mature the intestinal cells, as well as it helps to um, reduce the incidence of different infections. And it really helps to lower the risk of SIDS, which is very important as well. And then it helps with it's linked to lower rates of attention deficit hyperactivity disorder. And there's some protective effects hormonally as well from cancers. And so I wanted to put this in here because breastfeeding rates, I mean, I think we hear this a lot that they've increased in recent years. And for children born in 2011, about 80% of newborns were actually breastfed and exclusively, predominantly, or partly, but that's a good number, 80, almost 80%. And then the number drops to about 50% at 6 months, and then another into 27% after a year. So what is happening? There's a number of reasons, and there's some correlations there, but when you talk about rates across the United States, the Southern tends to have lower rates of breastfeeding, and then Western and the Northeastern have higher rates. So when I put this question in here, I saw some old data for Black women that I thought I'd share, and I actually didn't put it on the slide because I was going to poll you guys, but I can't figure out how to work my screen here. So I'm going to stay away from that. But I wanted to just kind of say that, the numbers are far smaller than what we've seen before. So I wanted to kind of read this to you. Oh gosh, I can't find it now. Um, okay, I'll keep going. But it's lower. And what can we do um to raise that? Oh, here it is. It's ever breastfed is about 75%. Any breastfeeding at 6 months is 50%. And then any breastfeeding at 12 months is 30%. And exclusive breastfeeding through 3 months is about 40%. And then through 6 months is roughly 25%. So for context, that it looks like it's pretty good. This is based on 2021, I believe. And so I wanted to kind of level set. My poll was going to be, are you in agreement with that? And do you feel like it's gone up? And what are some of the factors? But we'll keep going. I can't even see the chat if you're sending in notes, guys.
Well, I was going to ask, Doctor, if this was a good place for us to stop,
Yeah.
and because we could do phase 2 around breastfeeding.
Okay.
The chat is on fire with lots of
Oh,
comments. And the number one, so everybody knows, can we get your deck?
sure.
Okay.
Sure.
Or at the very least, let's work together, and how you had it broken out by disease state or diagnoses. If we could just have that section for those who are practitioners to use as a reference.
Of course. Of
Okay. So,
course.
okay, guys, I got that one in. The most recent one was, can we talk a little bit about vaping? And you made our brains go off with that one that I can't even pronounce. But
Just call it 7-0.
okay, 7-0. Can we talk a little bit about vaping?
Yeah, I didn't put vaping in here. I don't think I put it in my backup deck. I don't think so. But what are the questions like? What impact? I can look that up. I don't think I did my due diligence when it came to, I know it's a no-go in pregnancy. But I don't know the percentages off the top of my head. What is everybody thinking? Is this? I know that vaping is starting to be out of control in terms of the types of drugs that are sold, and there's different. It's not, I think the regulations are going to change very soon, and so I hadn't gotten my hands on the latest data. So I can actually look that up and get back with everyone if that's okay.
Thank you. Yes.
Yes.
Um, so when you talked about alcohol,
Mhm.
we hear different advice about alcohol, and I appreciate the conversation around caffeine. There's all that there's the noise about like pumping and dumping, and that a glass of wine is fine even during pregnancy. What what's and I don't I was writing furiously. I didn't catch what your guidelines were, like your simple guidelines. Is it like a hard no, or
You know
where do
what?
you
I didn't give one because I am of the mindset pumping and dumping is certain that's commonly used. And I feel like with the clinicians, and if you talk about wine versus grain alcohol, then that's two different things in terms of alcohol content. And you're talking about what trimester, and those sorts of things. I don't know that, I don't think it's like a hard no for a glass of wine, but I'm very, very reluctant to go with any of the brown liquors or the more stiff stuff in any capacity. I know that there is some conflicting data. As always, everything's controversial, but I can only present what I've seen in the literature.
Thank you. So no
Yes.
bourbon. Because I'm a Kentucky girl. Bourbon is my thing, but I'm also not of childbearing age. So there you go. When you talked a little bit about marijuana, and then you guys drop your questions in the chat too, and I'm trying to pull from the Q&A. Um, Okay, here's one. In case the mother has a medical condition and
Right.
experiences an MI, are there any alternatives to high dose aspirin that can be taken OTC? Or does the requirement of high dose aspirin, since I guess it's the most common, accessible, useful choice, override the health of the infant? And can something be done to the infant in case aspirin is taken?
Yeah, that's a great question. Um,
Could I first ask, doctor, for those of us who don't know this language, what is an MI?
a myocardia infarction,
Thank you.
heart attack. Um, somewhere similar, in some ways similar, but I'm trying to think when I went through the literature, the the high dose data with aspirin is just it seems like it's very detailed in terms of all of the things that can go wrong with aspirin. So when you're talking about deformities, you're talking about bleeding risk, and the list goes on. I don't know that I would feel comfortable, um,
Mhm.
recommending that. So I would say this. I haven't asked a cardiologist. I don't know what their perspective would be, because it's about bruising, and you want to make sure that patients are being monitored, because if they're high risk,
Mhm.
then I don't know if baby. I'm not sure. I'm not sure about the ranges there. I would think they could titrate upward, but not go beyond the 325 dose perspective, because I think that that's where you see all of the reports. That's where you
Right.
see the animal data. That's where you see the human data. So again, just watching that very closely, I think we'd have to kind of do a risk versus benefit.
Yeah, that's a good point. Um, and then so it would, if I understand you correctly, and to recap for those of us who are lay people, it's really contingent on the severity of the mom's condition,
Yeah.
I guess where she is in her pregnancy journey, right?
Right. Right.
Okay. And then if I understand you correctly, there is no over-the-counter alternative that would provide the same effect, right?
No, because if you think about, let me see, no, because Tylenol won't do it. Definitely won't do it. Um, and the other NSAIDs, um, not that I am aware of.
Okay. Thank you.
Sure.
Um, we talked a little bit about no, no, no. Let's go back to the hot topic of the day, depression and mental health, and SSRIs. So, you covered and hinted at how there was some question from the expert panel that the FDA had. Um, what I understood is you to say is that for that mama who's dealing with postpartum depression, the medication can be life-saving.
It can.
Um, and so clarify for us again, what leads what led to the concern? Are there what is the word, doctor? I guess there are risk for the baby or
Yeah. So you're referring to the SSRIs in the
yes.
in the
Mhm.
panel. So they talked about the role of serotonin, and I took some notes from it, so I'm gonna kind of reference them here. But serotonin plays a role, right, in fetal development, and they talked about how SSRIs disrupt serotonin system and how they work and how they really cross the placenta. So that means that not only is it working on the mom, but it's working on the fetus. And so a lot of what they were discussing was whether or not these treatments, number one, are worth it. It okay, two things. Treatment itself, is it, because the response rate is somewhere around, I believe they said about 19, 20%, low 20% in terms of resolving their depression and or anxiety. And then there was one person who said, you know, we've gotten away from discussing depression and the organic causes of depression versus putting everyone on medicines. And so they didn't, they were talking about, the therapy piece of it, um, and vying for more behavioral treatments and non-pharmacologic treatments. And then some were really talking about SSRIs because it's been shown to do several things in animal models and basic research, which was disrupt the individual neurons in the brain. And in mammals, it affects like social development, and it causes like autistic type behaviors. And it also has been shown to alter sexual behaviors as well. So that was one big area. And then they just kind of talked about the differences between Paxil, paroxetine, and Prozac, fluoxetine. And they talked about how the labels are even different in what is happening with postpartum hemorrhaging. That language needs to be strengthened in the warnings. And they talked about the role, some of, they seem to relate it to brain defects as well, and miscarriages and preterm births and low birth weight, and the list goes on, like it preeclampsia and postpartum hemorrhaging. And then they talked about if it's affecting the mom, is affecting the baby. And they talked about prenatal ultrasounds after birth, and they've shown that those behaviors were more jitters. They showed that the breathing is different. So there is something going on, and they linked it to, I mean, depending on who was speaking, they really talked about the changes on MRIs have actually shown alterations in brain development and
But then
speech and language and autistic and depression. Go
so
ahead.
they're correlating some side effects and influence on the child. But then I guess if you look at what the ACOG's, their
Right,
statement was the benefits outweigh the
right.
potential risk. Interesting.
They did, and there was no conclusion from. There was all these opinions and a lot of discussion. I was actually just giving you a debrief of what they discussed because your question was more about
Right.
what happened, like what is the discussion, because I think the other point they were making was, are pregnant women aware of all of this, and then can they make a decision from that with their clinician about what's appropriate for them.
Like an
Some people, yeah, so that was kind of the big discussion when you talk about brain and behavioral changes. And when you talk about a lot of these other things that I mentioned, you know, one of the speakers talked about, he asked his patients, and a lot of them didn't know. And so then there was an indictment on what is the education like and who's responsible for it. So
Right,
that was
because you
part of
have the
it.
mental health professional and then you've got the OB,
Right,
and sometimes they may not talk to each other per se.
right.
So,
Exactly. And even, OBGYNs, they were very adamant about talking about how quick the appointments are and how they don't really have the time to go into great depth but some said they did. And then they talked about the role of the pharmacist and how a lot of pharmacists are typically super busy. So that's why I'm glad we're having this conversation so that we can talk about some of this. And the ACOG guidelines I thought was very spot on in terms of, and I'm not disagreeing with them because I do believe that you have to look at what is, how severe is the mom? What is,
Right.
what is at stake here? And we know the number one preventable aspect of all of this is suicide. So if there is treatment that's needed, then treatment should be given. And but that is not my decision. It is up to, the individual and their clinician.
Right. So here's, and this is probably fairly general, the difficulties that that expectant mama has in sleeping. What would fall under like a safe, is melatonin? Is it,
Yeah.
there's so many little, or is this one that we need to save for the herbal,
No, no,
herbal
no, 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 no.
conversation?
So I actually melatonin was one that again, it's controversial. Everything's controversial. There's a good, there's a bad. So melatonin is a naturally occurring hormone in our bodies. And it's so our brains, when it gets dark, melatonin is released to tell us to go to sleep and stay asleep. And when people take supplements, they have to find the sweet spot. So um is it point 0.3? Is it 2 milligrams? Is it, and people have gone up to over 10 milligrams of this, and they oftentimes talk about the dizziness, the drowsiness, the hangover effect, the vivid dreams that they have. And some people are, they do it to because they're trying to regulate their circadian rhythm, meaning the internal clock that's in our brains that regulates what happens. And sometimes, like if you're on shift work or you work at night and you can only sleep during the day, or you jet lag or something like that, it helps to get your body back on rhythm. It's not meant really to be a sedative. And some people, and if they do, they might use it for weeks or days, but they shouldn't use it longer than 3 months, but some people do. And then there's ongoing studies that are looking at some other, neurological studies in melatonin. But for the average person that wants to sleep, I am not sure about magnesium glycinate.
Oh,
Um,
that was the next question. I see a lot of
that
moms
has saved
talking
my
about,
life.
yep,
I'm
mixing
sorry.
it. Oh, I said
Huh?
that was going to be my next question. So you're answering it. What about magnesium glycinate? And then I guess they pair it with tart cherry juice.
Yeah, I've heard that. I haven't done that myself. I've read that it's safe, and I have not had a chance to dig deep. Let me tell you why. Because and we're going to get to this and we can do this next time, is when you are picking a supplement, not all of them are created equal.
Oh, that's right.
So when you not trying to spend money for people, the budgets, or
Mhm.
some some are more quality than others. And the reason I say that is when you're picking a supplement, pick something that is either USP verified or NSF certified. And these are third party companies that work separate from the manufacturers, and they validate not only no contaminants, they make sure there's good manufacturing practices, and they also help to ensure that what is on the label is actually in the bottle. Because one of the biggest things that happens with supplements is the label can say, make this glorious claim, and then the active ingredient that's supposed to do that is not even in the bottle. So you have to be mindful of that. And when you're picking a supplement, pick one that actually you got to flip that label over and look at it and see if the active ingredient is actually present. and then it matches the amounts that you need. So back to magnesium glycinate, which is different from melatonin, it is it works pretty quickly, 30 to 60 minutes before bedtime, and it allows people to go to sleep and stay asleep. It seems what top line that I've read seems to be pretty safe and effective, but it is different. And it also helps with anxiety. So whatever bedtime dose, like the formulation I have is by Life Extensions, and then Thorn has good products as well. Um, and actually, if you go to my website, I can give you a discount because
Oh,
I do have,
put that, remember to, I'll drop that in
I
our,
do
I'll
have
drop that in our
Thorn.
chat.
And yeah, you can go
And
to my website and look. But my point is not selling anything here. But I wanted to just say that absorption is ultra important because a lot of these products have fillers. They have a lot of sugars. They have dyes. They have, things that don't work. And so when you're using these products, melatonin, magnesium glycinate, you have to look for those ingredients in the right amount.
last question, I promise, for this time. Talking about naturally occurring substances, there's currently a debate around the research that showed folic acid reduced the incidence of birth defects was
Uh-huh.
with folic acid, right?
Uh-huh.
So, but then there's that folic acid is not a naturally occurring whatever, if I'm quoting this right. Um, so for those mamas who are taking folate because it is natural, what's your opinion? Is it going to provide the same benefit as
Benefit.
folic acid? Yes.
Yeah, in one is actually not active until it hits the body. So, um, and I want to say it is, gosh, I'm trying to remember the science. I want to say it's folate, and I don't have my notes on that right here, but um, yeah, folate. I want to say it's like a prodrug, but I am not totally sure about that one.
We'll show that one for our next
Yeah,
time.
I can get that for sure because I just actually got that question and I haven't had a minute to research it. So thank you for the question.
Yes, thank
Um,
you so much
yeah,
for
of course.
this amazing conversation. Thank you. Our group is still here. We're still hanging on. We still have questions about vitamin D and layering supplements and all that other good things. But thank you for being part of tonight's session to our viewers. Thank you, Dr. White, for sharing your expertise. This was absolutely amazing. We will have the recording, and then our team can work with you, Dr. White, to pull those slides that were by disease state or whatever and put them in a standalone with your website and contact information. And then we'll send that along with the recording. Because I could see where some of our doula friends and midwives and other practitioners would love to have that as a quick reference.
Of
Um,
course.
so we know that breastfeeding comes with lots of love and lots of challenges, and we'd love to dive a little deeper into your question about why do we see that the breastfeeding rate is lower among Black women. For those who missed our conversation last week with some amazing, there was an IBCLC and a number of other breastfeeding advocates. Take a peek because they had perspectives. We didn't come up with any answers per se, but they did have a perspective. And then we'll continue that conversation with our phase 2. So stay tuned. We will start begging Dr. White tomorrow to look at her calendar and come back. And then for those of you that are around on September 23rd, we're going to have a brilliant young woman who's going to talk to us about our sexual health and HIV. For those who don't know, HIV infection is highest among Black women, despite us not being the largest patient population. And so we need to be informed on how to protect ourselves and each other. So bring your friends, even if they're not expecting, because this one is beyond the perinatal period, right? And so September 23rd, you can find it on our website. Dr. White, thank you again, and everyone have a good night.
Thank you, everyone, for attending. And thank you, Marie, for having me. This has been
Oh,
wonderful.
it
Thank
was.
you.
I knew it would be wonderful. Thank you so much. I appreciate it. We'll talk soon.
Okay, bye bye.